Good evening, everyone, and thank you for joining our Digital Infoday session this evening. This webinar is going to focus on early diagnosis of myeloma to initial treatment, and the webinar will be recorded and available for you to watch as soon as we can get it together. Okay, many thanks. My name's Kim and I'm one of the myeloma information specialists here at Myeloma UK. I work alongside my colleagues Ellen and Sarah, and our role is to support and offer information to patients and family members who get in touch with us. So please don't ever hesitate to contact us or get in touch if you've got any worries or questions or just simply need to have a chat. We'll be there for you. So for those of you that are new to Myeloma UK, our organisation supports anyone affected by myeloma or an associated condition such as MGUS or smouldering or asymptomatic myeloma or indeed amyloidosis. Our work is always patient focused and we try to make sure that our patients and families feel empowered, informed and supported excuse me, through our work. As an organisation, we, like many other charities, rely on fundraising and donations, and we're always very grateful for the support that we can get, and any contributions are very welcome. Every penny counts, so everything makes a difference because we receive no government funding. I'd like to welcome this evening's expert, Dr. Fenella Willis from St George's Hospital in London. Dr. Willis has been a consultant haematologist at St George's Hospital and has had an honorary senior lecturer post in the medical school since 2004. She's the clinical lead for myeloma services at St George's Hospital and has been the principal investigator in a wide portfolio of myeloma hemo-oncology clinical trials and is the co-chair of the Myeloma UK Early Diagnosis Steering Group. I'd like to hand over to Fenella now so that we can begin our myeloma journey from diagnosis to treatment.
So I'd like to welcome everybody. It's very strange to speak to you all across a chat room rather than face-to-face, but hopefully today we can go through the early stages of diagnosis with myeloma, what that means, and also some of the initial discussions and treatments that you might experience following a diagnosis. So the talk will cover what myeloma is, what causes myeloma, and the initial treatments. And it can be supported by patient booklets, which Myeloma UK also provides. So it's useful to know that any information covered in this talk is also available in booklet form. Obviously, it's important to have some key take-home messages, and I think one of the things I'd like to hope that everyone understands by the end of this talk today is understanding that myeloma is a type of cancer of an abnormal plasma cell, and plasma cells are types of white blood cells that normally live within the bone marrow, and that's why in myeloma we often need bone marrow samples to get a diagnosis. The causes of myeloma are not fully understood, and we'll go through some of the associated links, but as I say, there's a lot of ongoing research to really understand the diagnosis of causes behind myeloma. And I think it's important to understand the aims of treatment, firstly to prolong life and prevent damage to the body caused by myeloma, but also it's really important to have a good quality of life. And often we are balancing those decisions with patients about not only prolonging life, but also achieving the best quality of life at the same time. It's useful to have some key facts. Most patients say to me they've never heard of a diagnosis of myeloma or heard of myeloma before their diagnosis. And that's because it is a relatively rare condition. However, numbers-wise, 5,700 people were diagnosed with myeloma in the UK in the last year. And around 17,600 people are living with myeloma in the UK. because obviously patients will be at all stages of their journey from diagnosis and along that treatment pathway. Myeloma accounts for 15% of blood cancers, but actually only 2% of cancers. And it's important when we're looking at sort of nationally at how money is attracted to certain cancers, that that's understood, because when we look at blood cancers as a total, actually blood cancers are the 5th largest group of cancers. But obviously, when you look at individual cancers within blood cancers, obviously they're a much smaller group. Myeloma predominantly affects older people over the age of 65. However, we have to remember about a quarter of patients are diagnosed with myeloma under the age of 65. And so it's really important that any of our primary and secondary care clinicians understand that it's not solely seen in people of older age. So what is myeloma? Well, I touched on very briefly that myeloma is derived from a blood cell called a plasma cell, and plasma cells, their normal function in life, they're a type of white blood cell, and their normal function is to produce antibodies to help fight infection. And in our body, we're normally exposed to lots of viruses, bacteria, abnormal cells, and our body constantly has to produce antibodies in response to that, so that we can hopefully live a healthy life. Now, normally we produce a wide repertoire of antibodies, and that's obviously shown in this picture in lots of different colours of antibodies, but we produce a huge number of different antibodies because we're exposed to a huge number of different target genes that we have to respond to. What happens in myeloma is that you have an abnormal cancerous plasma cell, and that still produces a protein or antibody, but it is an abnormal antibody, and that antibody is often, you will hear the terminology of a paraprotein. What that means is the antibody, rather than being of lots of different types of antibodies, is that you produce a single type of antibody because there is a single clone of cells. And actually the diversity is much reduced. The importance of that is that means that when people get myeloma, is the background normal plasma cells in the bone marrow are reduced. And as a result of that, a patient with myeloma's ability to fight infection is markedly reduced because they're not able to produce the same number of antibodies to fight infections. So what is a paraprotein? Well, a paraprotein is made up of both heavy chains and light chains. And you may be told that you have an IgD or an IgG or an IgA myeloma, or the doctor might say that you have a light chain myeloma. And obviously, what does that mean? Well, it means that your particular myeloma is involving a plasma cell that is producing a paraprotein that is specifically producing heavy chains of one type and light chains of one type. So if it's an IgG kappa myeloma, it is producing an IgG paraprotein with kappa light chains, and it will be very specific. It won't swap from being an IgG to an IgA. The myeloma will retain that particular protein throughout its course. The only changes that can sometimes happen is that you can sometimes go on to get some changes further along the disease, where the disease evolves with time, and sometimes there can be a change from having a whole paraprotein to just having a light chain. But it's useful, the usefulness of having these paraproteins in a sense is that we can use it to monitor and track the disease. And certainly during the course of your treatment, regular blood tests will be used to monitor and track the disease and the response to any treatment. So how does myeloma affect the body? And why does it affect the body in that way? Well, I think obviously many patients initially present with certain symptoms which are related to usually to the damage or problem that myeloma is causing within the body. So bone pain can be a very common symptom that someone might present with. The extreme end of that would be actually potentially a broken bone, but bone pain can occur particularly in the back, or can occur in any part of the central part of the skeleton, because as I mentioned, myeloma occurs within the bone marrow, and the bone marrow in an adult is in the central part of the skeleton. Why do bones break easily? We'll come on to in a little while. But as I say, pain is a very common symptom, and particularly the back. And I'd say to many patients, the reason you get back pain is that when you stand up, you put a lot of pressure through your back. And so if there is a problem with any of the bones in your back, you're going to potentially get pain in those areas. Recurring infections is related to the problem I've already mentioned around the bone marrow preferentially making myeloma cells rather than normal plasma cells. And as a result of that, you get what we call a background suppression of the immune system and reduced ability to fight infections. Kidney damage occurs actually because of the protein that is produced. So we've talked about the light chains and the heavy chains, and particularly the light chains can be damaging to the kidneys and can precipitate in the kidneys, causing problems with the kidney function and scarring within the kidneys. And if this is picked up early, actually, we can reverse some of that damage. However, unfortunately, if the damage is very advanced at the time of diagnosis, that can be quite difficult to reverse. But one of the reasons patients presenting with kidney damage are often we want to treat them very quickly, is to really try and get on top of any potential kidney damage. And fatigue can occur for many reasons. One, just the burden of the myeloma disease. Secondly, there's often associated anemia with myeloma, partly due to the effects on the bone marrow function and partly due to the effects on the kidney. So as I mentioned, we'll talk a little bit more about myeloma bone disease. This is a complicated slide, my apologies, but it's quite important to understand why myeloma causes bone disease and obviously what we can do to help with that. So myeloma cells, as I mentioned, live within the bone, in the bone marrow, which is in the central part of the bone. And myeloma cells produce a lot of signals which actually affect the surrounding cells within the bone to different degrees. So myeloma cells will send signals or messages to what we call stromal cells, which are important in nurturing the myeloma cells. They live together in harmony and support each other. Now, myeloma cells also produce proteins which can affect the bone building cells, which are called the osteoblasts, and the bone breaking down cells, which are the osteoclasts. So normally there's a balance between the osteoblasts and the osteoclasts so that you are constantly making new bone and constantly breaking down bone in equilibrium. What happens in myeloma is that there is a suppression of the osteoblasts and an increase in the number of osteoclasts. So the balance is lost, and as a result of that, you get breakdown of bone in excess to bone formation. This can cause the typical signs in the bones, which are called lytic lesions. And if you see a plain X-ray, on a plain X-ray, it will look like there's a hole in the bone or a weakness in the bone because of where the bone has been destroyed by the myeloma. Now, if that is very marked and very severe, it can compromise the side of the bone, which we call the cortex of the bone, and effectively that can mean that the bone is very easily broken with very little stress. Obviously, what we try and do is to stop that from happening, and that can be due to a combination of treatments, one being treatment of the myeloma itself, and secondly being treatment directly to trying to get the balance back between the osteoblasts and the osteoclasts, so directed actually at the bone damage. So what causes myeloma? Obviously everyone is very concerned when they're diagnosed with cancer as to whether there is a risk of that cancer being passed down the family, and whether they have done anything within their lifestyle that might have affected it, i.e. what we called an acquired risk exposure to environmental factors or chemicals. We do know with myeloma that there are certain things that increase the risk, although the clear risk factors are not always very apparent when you speak with patients. So in terms of inherited risk, we know that if you have a family member with myeloma, there is a familial link with some types of blood cancers, but it doesn't necessarily mean that your child or your offspring will get myeloma. It's not a genetic link as opposed to a clear-cut sort of genetic abnormality that would be picked up at birth. And likewise, environmental risk factors, we know that there may be some sort of environmental risk factors that might slightly increase the risk. So certainly exposure to sort of pesticides, agriculture, certain chemicals, those or increased risk of certain genetic changes, but not clearly linked to myeloma. So if we go on to the next slide, in terms of causes of myeloma or what we do know about links, we do know that myeloma occurs more frequently as we get old, and that's partly because as we get old, we have been exposed over our lifetimes to potential environmental factors that might increase your risk of genetic changes that will predispose to types of cancer. We know that in ethnicity, that myeloma is twice as common in the African or Afro-Caribbean population. And as I said, if you have a family history of myeloma, there's a very slight increase in incidence in family members, so 10 per every 100,000 compared to 5 per every 100,000. So there is a slight familial link. There is a slightly increased risk in men over women. And as I mentioned, certain environmental factors might predispose to an increased risk. But I think the only thing that we can say is uniform and is in all patients a risk factor for myeloma is the pre-existing condition MGUS. So MGUS is a condition where patients are found to have a paraprotein or an abnormal light chain, but have no evidence of myeloma at that point. This is due to a very small clone of cells, abnormal plasma cells. As I say, at the point at which it's picked up, they don't have a diagnosis of myeloma, and they don't have any evidence of any damage to their body, as we would see in someone diagnosed with myeloma. But all patients with myeloma have gone through a pre-existing MGUS state, although this may never have been diagnosed or never been picked up. So what is typical? So that's always one of the difficult things, is when someone is diagnosed with an illness, is what is my journey going to be? How is this going to affect me? Have you got anyone who's exactly like me who give me some information? And it's quite difficult because actually patients are very individual, and their patient journey can be very individual. There is a wide spectrum of disease from this MGUS state, where patients don't have any symptoms, and it just requires monitoring. To smouldering myeloma, where again patients don't have any symptoms or end organ damage from the myeloma, but actually they do actually, in the sense that when we do a bone marrow biopsy, they have sufficient numbers of abnormal plasma cells on their bone marrow biopsy to make that diagnosis of myeloma, through to obviously patients that are symptomatic of myeloma and needing treatment. No two individuals are alike and no two patients are alike, and what each patient brings to the journey is their pre-existing medical conditions, their pre-existing fitness. Every individual will present slightly differently, and so the start of their journey may be very different even before you've started any treatment or any discussions. As we mentioned, there are different subtypes of myeloma. So, obviously when patients are talking to each other, they will find out that some individuals might have this IgD or IgG or IgA myeloma, and some patients may have a light chain myeloma, and some patients may have a non-secretory myeloma. And what that means is that, as I said, we can use this to monitor patients, but sometimes actually some of those subtypes have a slightly different risk of potentially having problems maybe with kidney disease, or the non-secretory subtype. It might be very difficult in terms of monitoring in comparison to some of the secretory subtypes. So the journey might be slightly different in terms of us having to manage the monitoring in a different way. But what is known is that for all patients with myeloma, the disease is typically what we call a relapsing and remitting disease. When we start treatment, our aims are to get the condition under control and keep it under control for as long as possible. But at some point it will become active again and require further treatment. And we'll go on and have a look at what that means in terms of a journey in the next slide. So this just shows it sort of in a slide form. So the pre-existing level, this is looking at your paraprotein level over time. And as the paraprotein rises from this patient with MGUS or smouldering myeloma, the burden of the myeloma is increasing to the point that a patient may start to get symptoms, and those symptoms being bone disease, so pain or back pain, or potentially a bone breaking, or impairment of the kidney function, or increasing fatigue or infections. We would then start treatment, and as the treatment starts, the paraprotein level will start to come down, and we'll get to a point where it either disappears completely or may be stable at a low level, but is unchanging. And we call that a remission or a plateau phase. Patients will then be continued to be under monitoring, and at some point the paraprotein level will increase again, and it will get to a point where we think that actually further treatment is required, and a second course of treatment will be started with further response. And that process can go on, obviously, over a number of years. So I think this is our first break to have some questions and answers.
Thanks for that, Fenella. Sorry, I didn't unmute my microphone then, so I apologise for that. So yeah, that was a really great introduction to myeloma, and we have had a few questions in. Bridget and Rachel asked about what the journey would look like for a myeloma patient after diagnosis, but you've kind of covered a lot of that really. Another question that we do get asked a lot of is around genetic links to myeloma, and how much does a family history of myeloma affect a person's chances of actually getting diagnosed. just wondered whether you might be able to just expand on that a little bit more.
Yeah, so as we said, obviously there is a familial link with myeloma. So we know that in some families, it may not even just be myeloma, actually, it may be more broader in terms of B cell cancers. So we have certain types of white blood cells called lymphocytes, and particularly B lymphocytes are the lymphocytes in which plasma cells develop from. And so within families, there is definitely a familial link in terms of an increased risk of B cell cancers, blood cancers within families. But it is quite a low one. So as I said, obviously this comparison between 5 per 100,000 to 10 per 100,000, it's not a that you're definitely going to get a B cell malignancy because your family have had that. So there is this link, and then the Afro-Caribbean population, there's definitely increased risk within that population of both MGUS and smouldering and symptomatic myeloma.
That's great. Thanks for clarifying those things for us, Fenella. That's great. I think we, having questions from our audience is really helpful. So, thank you to, Bridget and Rachel for getting in touch with us with those questions. I wondered whether it was possible now if we go on to talk a little bit about treatments. So would you be able to carry on with that, Fenella?
Yeah, absolutely.
That's great. Thanks.
Okay, so obviously it's always a shock to get a diagnosis of myeloma, and then obviously the next, I suppose, decision to be made is around treatment, and these are really important decisions. First of all, is treatment needed for everybody? And actually, the answer is no. Actually, at the point of diagnosis, not necessarily everybody needs treatment straight away. So why do we treat some people and why do we not treat others? And so that's partly down to us separating between what we call this symptomatic myeloma and this asymptomatic or smouldering myeloma. And so we will tend to obviously want to start treatment if we can see that there are any symptoms or complications related to the myeloma. So particularly if we can see a patient has got anemia, their kidneys are not working as well as they should be, they've got significant problems with bone pain and bone damage, as it were, from the myeloma. Those would definitely push us to start treatment. There are a subgroup of patients that fall into the high risk end of the smouldering myeloma. These patients we know have a very high risk of needing or getting symptoms from their myeloma within the 2-year period, sort of over 80%. And those patients, although are not necessarily symptomatic at the time, because the risk is so high, generally we will recommend that they start treatment. So that's a cohort that is sort of in between, as it were. But many patients that have smouldering myeloma, where there is no evidence of any end organ damage, they're not anemic, their kidneys are fine, they are not getting recurrent problems with infection, and they're not getting any problems with bone disease, will just be monitored very closely. And so those patients can often be monitored on a sort of 3-monthly basis through clinic, and we wouldn't necessarily rush into treating immediately. And partly the reason for that is that some of those patients will behave more like an MGUS than a myeloma, and actually may be stable for some years. So rushing in really doesn't necessarily do them any favours. Now, there are some obviously clinical trials looking around that at the moment, because obviously the question is, if you went in earlier, would some of those subgroup of smouldering patients do better or not? And certainly that is a sort of clinical question that continues to be looked at and addressed. What's very important is if you're not having treatment initially is that you are very actively monitored, and that you're vigilant for symptoms and report symptoms if you're concerned about them to your clinical team. Obviously, when you have a discussion about treatment, it's really important. My aim with any discussion with a patient is to get the patient to the point that they feel able to make the decision about treatment. It's not me forcing them to have treatment. It's about them understanding the diagnosis of myeloma and what the benefits of treatment might be and how we're going to support them through that. And obviously what we're trying to do is improve the quality of life, because often at the point of being diagnosed, patients are quite unwell, may have a lot of symptoms, and actually, are trying to find a way of feeling better, and treatment can often help with that. So we want to improve quality of life, as well as prolonging life. And as I say, we also have to look at the risks of treatment versus the benefits. And the risks and benefits, so it's always very difficult because we're talking about obviously what we think in terms of the combination we're offering, what benefit it might have in terms of prolonging life, what we expect in terms of the response to that treatment. But then we'll also discuss in great detail what potential side effects might happen, partly because although those are not going to happen in all patients, we do need patients and clinical teams to be very vigilant about that, because we want to be able to actively manage any side effects that happen so that actually the treatment is tolerated well. And we can control the disease and reduce the symptoms. So it is always a balance, and as I say, it often takes quite a few discussions to get to the point of everybody understanding exactly what is on offer in terms of treatment, why those treatments are on offer, what the options are, because there may be some options in terms of potentially clinical trials, or it's not always that there's only one option there. And also, particularly in recent times, some of those options might be the balance between having something that requires trips to the hospital, or having treatments that can be predominantly administered at home. So there are quite a lot of important discussions that need to be had, and it's really important that as a patient you make those decisions with all of the information you need. So what types of treatment? So it's unfortunately quite a complex treatment pathway, because it's not just one type of treatment or one tablet or one injection that can give the best response. We're often using a combination of 2, 3, or 4 different drugs to try and get the best response that we require. And each of those medicines that we're using effectively have a synergistic effect. So if we were only to use one of the medicines, we would not get as good a response as if we were to use 2 different medicines. And if we add in a third, we can find that there's even more of a response. So it's really important to understand that they are all very important for different reasons, but they actually work together. So we use drugs which we call immunomodulatory drugs. So those include drugs such as thalidomide, lenalidomide, pomalidomide. There are steroids, which unfortunately are the backbone of most of our treatments and can be one of the ones that is more difficult to tolerate, and needs to be sort of carefully sort of monitored. Proteasome inhibitors, so these can be given either intravenously or under the skin, so subcutaneously, or it's tablet form at different points of the treatment pathway. We have monoclonal antibodies, so these are antibodies that particularly target proteins on the surface of the myeloma cells, work in a very different way to the other agents. histone deacetylase inhibitors, and then we have chemotherapy as well, which is often given in tablet form. So that forms our sort of anti-myeloma treatment. But alongside that, it's really important that we have supportive treatments. So these are treatments that aren't necessarily changing the myeloma itself, but are actually supporting some of the symptoms that are really critical with myeloma. And so, actually need to be given at the same time. So that may be radiotherapy. Radiotherapy can be sometimes used at local sites for if there is pressure on important structures. So in the spinal cord, for instance, it might be used at a treatment level dose for that, or it may be used for control of bone pain. Bisphosphonates are important for managing bone disease. Erythropoietin, which we give sometimes if patients have significant problems with anemia. Antibiotics for management of infection and prevention of infection. Bone pain being such a big issue, is often a diagnosis, so pain relief is very important, and that can be quite complex in terms of the different types of pain relief that we need to use. And then for patients that have got significant spinal problems, we often use a procedure called either vertebroplasty or balloon kyphoplasty, which is where we put some cement into the vertebral bodies to stabilize the bone which is in the spine, which is fragile as a result of the myeloma, and stopping that bone from collapsing. And that's really important actually to be looked at diagnosis, but also at different stages of the myeloma journey, because if we can maintain someone's height and normal posture, it helps enormously in terms of management of pain and also management of their disease. So it's really important we look at spinal disease at diagnosis as well. So with that initial treatment, every patient that is diagnosed with myeloma, their case is looked at and discussed at what we call a multidisciplinary team meeting. And that meeting will have a histopathologist that will look at the biopsy results. It will have a radiologist that will assess all of the imaging results. It will have the expert doctors that will discuss the treatments, and also the clinical nurse specialist who is really very important in terms of the patient voice at those multidisciplinary team meetings, partly because they often have very good knowledge of a patient and their patient's wishes and things. So once that discussion is had, the discussion then goes back to the patient in terms of what the team have felt might be the best option. It's not that we are completely rigid in that. Obviously, it's obviously working from experience of what we know from experience, looking at patients in terms of symptoms, what we call comorbidities, their other health problems, their age and how frail they are, and what we think would be the best option. And it might be for younger and fitter patients that we take them down a slightly more intensive pathway, with a view that we will be trying to do a stem cell transplant at the end of that induction pathway to consolidate their response. With an older, less fit person or a frail elderly patient, we would again treat with an induction protocol, which may be quite similar to what we do with the younger patients, but they would not necessarily go on to the stem cell transplant. And through all of that treatment, there would be obviously supportive therapies to help with bone pain and management of things like infection and anemia. So we have these combinations that we use. So you might be told that, we are proposing a combination called VTD or CTD. So, and what does that mean? So each of the combination initials stands for a drug that we are proposing to give. So the mnemonic is very easy to understand, as it were. As I said, the option that we give may vary according to how frail or how fit we feel a patient might be, and also whether there are any clinical trials on offer, because potentially sometimes there may be clinical trial options that might use some of these backbones, but might also allow exposure to medicines that are not currently out and accessible through the NICE process. So all of these combinations are backed up with clinical trial data. So why we use these combinations is it's a journey that the myeloma community has gone through for many years, and our best treatments are always evaluated against the newer treatments to assess whether the newer treatments are better than what we currently use as our best treatment. And that is often through large clinical trials. So the UK has been very good at conducting large clinical trials, really trying to get the best treatments to patients at the earliest opportunity. So that's, obviously one of the reasons why, why we have these combinations. And one of the things that's important with any combination that we give is obviously how it's delivered. And as I say, some of the combinations will be purely tablet-based, so like CTD, which is purely tablet-based, and some of them are, a combination of injections plus tablets, such as VTD. So, it's important to understand that when these discussions are had. If you are going down the stem cell transplant process, what happens and when does that happen? Okay, so it's really important that before we start collecting stem cells, that we have the myeloma under control. So the induction treatment will usually last for at least sort of 4 to 6 months. And we will be monitoring with each cycle of treatment to assess the response to that cycle of treatment, with the aim that we can see that the paraprotein or the light chain, whatever we're monitoring in you as an individual, has responded and come down. Ideally, to the point that it's reduced of 90% from where we started. And the doctors will talk about partial responses and very good partial responses. This is to do with how low the protein level has come from its original baseline. When we think we have got to the point where we've had a good response, we would usually do a bone marrow to confirm that, and then once we're happy that we think we've got a good enough response, go on to the stem cell transplant pathway. Now that requires several steps. The first step is to collect stem cells, and stem cells, thankfully, we can collect from the blood rather than from the bone marrow. So what happens is that you're given some chemotherapy treatment and some growth factor injections that stimulate the bone marrow to release the stem cells into the blood. And about 10 days after the chemotherapy treatment, you're ready to have those stem cells collected in a process that we call apheresis process. So the blood is processed through a machine, and the stem cells are removed, and the blood comes back to you. Once we've got sufficient stem cells, then the second phase is planned. And that second phase may be partly outpatient based or partly or wholly hospital based, depending on which centre you're at. But what happens is that you receive a higher dose of chemotherapy, and then 24 hours later, the stem cells are given back. Now, the reason for doing that is that it's trying to reduce any residual disease down to a lowest possible level. So the higher levels of chemotherapy are to ideally get rid of the residual disease. But without the stem cells, that would damage the bone marrow for a very long time, and potentially the bone marrow wouldn't recover. So you would have a very long period of time without any bone marrow function. The stem cells help the recovery, so that actually the bone marrow function is only suppressed for about 2 weeks before it recovers, and you're able to go on sort of that recovery pathway. The recovery tends to take about 3 to 6 months, however, afterwards, because it is quite a big procedure. Certainly the risk of infection continues for that period of time, and it does require regular support and follow-up. So how do we assess disease response? So as I say, luckily we can most of the time assess disease response through blood tests, and that will be done usually on a monthly basis or once per cycle, depending on how long the cycle is. It's no point in doing it usually more frequently than that, partly just because of the biology of the plasma cells. If you do it more frequently, you don't always get a very accurate or very clear result. So once a month is generally sufficient. As I say, there are a small number of people that might have this non-secretory myeloma, which is slightly more difficult because we can't use blood tests to necessarily monitor their response. Once we are looking at these proteins, as I mentioned, we look at the level of reduction. So once we can see that the protein from baseline has reduced by 50%, we call it a partial response. Once it gets down to 90%, we can call it a very good partial response. So there are different levels of response, and we are aiming really to get the disease down to the lowest level. Ideally a complete response or a stringent complete response where we cannot see the disease at any level. However, not all patients achieve that, and it doesn't necessarily mean that we can't carry on with treatment or with the next stage. The duration response, however, the reason we like to get to the very deep levels of response, so this complete response or this stringent complete response, is that we do know that actually by achieving that level of response, we often have a slightly longer remission period. And obviously what we're trying to do is have as long as possible to prolong life and have a good quality of life. And having the myeloma under control for a long period of time prolongs life and also improves the quality of life. And also improves symptoms. So, we do really want to get as good response as possible. And we know that the best chance of getting the best response is often at diagnosis in this first treatment. So what about maintenance treatment? So maintenance treatment is one that you may hear about. Certainly within clinical trials, we've been using maintenance treatment for some time. Myeloma UK is currently going through a process with supporting the NICE application for maintenance treatment after autologous stem cell transplant with lenalidomide, and we do know that sometimes in some groups of patients, maintenance treatment is likely to prolong that plateau phase or first remission. However, it may not be for everybody because you still require being on treatment, and we have to remember being on treatment may in some people also have its side effects and its difficulties. So we don't necessarily say maintenance would necessarily be for everybody, but there are definitely a cohort of patients that would potentially benefit from maintenance treatment, and so it's one of the things we would potentially like to consider in patients. So, as I said to you, I think it's really important as a patient that you take an active role in making a decision about the treatment. you can do that by really asking questions. Don't be afraid to ask questions. Don't be afraid to come in with a list of questions as well, because I know in the clinical setting it's quite difficult. Sometimes you might have a list of questions and you get into the clinic room and suddenly those questions go. Don't be afraid to bring a friend or a relative in that can ask those awkward questions that you don't feel quite comfortable about asking, or maybe you haven't even thought about. Sometimes having a second person in the room is really, really helpful. And they also potentially are the ones that know about what you're worrying about and also know the things that you're struggling with that you may not have really appreciated. So it's really, really helpful to have that second person in there when you're trying to make these choices. Be aware of the risks and benefits. It's sometimes quite tricky, particularly if you're offered a trial option and a non-trial option in terms of treatment. Phone people like Myeloma UK. There will be potentially other people that have asked those questions. Ask within the clinical nurse specialist whether there are people that you can ask that might also have experience having to make those choices. So don't be afraid to really ask those questions and look at, see what the risks and benefits might be in terms of, if you're a busy person, it might be one treatment is much more labour intensive and requires many more hospital visits than another, and that may not suit you. There may be all sorts of reasons why you might choose one treatment over another. Always be vigilant. So I think it's really important to be honest about your symptoms, because although we try very hard to be able to pick up when people potentially have side effects, sometimes it can be difficult. And I think in the sort of times when we're having remote consultations, it's even more difficult. If we're not visually seeing a patient, we are relying on people telling us what's happening and in detail. And although we will ask lots of searching questions to try and get that information out, it's really important to report symptoms like pain or tingling or fatigue, sore gums, weight loss, or your family members or friends to report those to us. And as I say, certainly most hospitals have a setup where obviously the clinical nurse specialist can be contacted directly out of the clinic setting. And I certainly know that our clinical nurse specialists feedback on a daily basis all the queries and concerns that they have been coming from patients that day. Compliance is also really important. As with any treatment, if you're not taking it appropriately or properly, because it's causing a lot of problems in terms of sickness or diarrhea or constipation, those side effects, if you're not telling us about them, it's very, very difficult for us to manage it. And ideally, we want to manage it before you stop the treatment. So we can do a lot of things to help with symptoms, to dose modify treatments, to really help you through that treatment pathway. So I think we've got another sort of question and an answer session.
Yes, thanks for that, Fenella. Sorry, I was having a little trouble with my unmute button again. Sorry about that. So yeah, that was really informative, and I'm sure that was really helpful. In fact, when you discussed about maintenance treatment, we'd had a question in from Hannah about that. So I think that's probably answered that question for her. But another question that we've had that was submitted by Reyes, he's asked, how have treatment plans changed since COVID-19?
Well, it's very, very important. Actually, we're quite lucky in many ways is that we have had more flexibility in terms of some of the drugs we've been able to give since COVID-19. So I think that's been, we have obviously tablet-based treatments and we have obviously injection-based treatments. And some of the tablet-based treatments we have been able to access at earlier time points in a patient's journey that we hadn't been able to get hold of before, because of the fact they recognised that patients really were trying to minimise coming up to the hospital. So that's one of the ways that has changed. We've been lucky that one of the treatments that is being given at second line, so daratumumab, has become available in a subcutaneous form during lockdown, so that's been very helpful. There's been quite a lot of initiatives to try and see whether we can deliver more chemotherapy in the community. So things like Velcade being delivered at home. That's not available in all areas, but certainly there's been quite a push to try and get that availability for some of these medicines to be given in the community, which haven't been necessarily given uniformly in the community before. So that's certainly been quite important. Some of the bone treatments, so patients that have been established on the bisphosphonate treatments, the frequency in which they were having bisphosphonates may have changed, or some patients may have been switched for a period of time to tablet-based bisphosphonates. So some of the supportive care treatments certainly would have potentially changed as well.
That's great. That's really helpful. Just to let everybody know that we're just running a little bit behind at the moment, but if you do want to stay with us, we're going to be talking next about a few hints and tips really on managing your appointments. If you can stay with us till the end, that'd be great. But if you can't, we are recording the session and it will be available via the website soon. So I'd just like to hand back to Fenella about to discuss about a few hints and tips about appointments, if that's possible.
Thank you. Okay, so as I said to you already, it's really important to get the most out of your appointments, and I think that's particularly important at the moment where not all appointments may be face-to-face. So try as much as possible to, before an appointment, write down what symptoms you're experiencing, really clearly and simply. Don't downplay them. We can try and interpret them. It's better to get more information than less information, but really do try and clearly write down what symptoms you're getting, what's triggering them, when are you getting them, and what have you already tried to do to try and help with that. I say bring someone with you to an appointment. It's really important, and take down notes before an appointment so you can really prioritize the questions. And I know a lot of my patients come with, they say, their shopping list of questions, and the order in which they really want to ask them. Also it's quite important to sometimes take some notes in that appointment, just to be able to remember what's been said. Because you will get a record of that consultation with a letter, but it does take a little bit of time, and sometimes it's good to be able to go home, particularly when you've got a family member which may ask what was said, and what did they suggest, and you can't necessarily always remember everything, so it's absolutely fine to take some notes during the appointment. Obviously, if you're getting a telephone call, okay, which I think is, it's actually in many ways fantastic. I've had many joint telephone calls where I'm put on speakerphone with, I think, the whole family, and I think it's really, really, useful because it means that you don't have to wait for hours in the outpatient setting. But it's important to have a quiet area, to have a good signal. And no interruptions, and obviously to be able to hear the phone. So sometimes mobile connections can be a little bit difficult, particularly if people are on the move or in their car or something like that. So it's ideal, to think of it as having that appointment, sitting down somewhere comfortably so you can obviously ask the questions in comfort, and having your list by you when you do that. And as having someone else there is also really important. So treat it like a normal appointment rather than, trying to do your shopping and then getting caught out with an appointment at that time. Because if you're ready for it and you've prioritised and got all your questions to hand, you'll get much more out of that consultation. And then obviously information, the importance of information. You know, why do Myeloma UK put so much into providing resources for patients? Well, you know, obviously they're patient-centered, and they know that it's really important when someone gets a diagnosis of myeloma to understand their diagnosis, to have control over their disease, and to be able to make the right decision about their treatment and care. And that requires information, and that information can be sought in many different ways, but obviously written information is exceedingly helpful because you can go back to it and you can absorb it over a period of time rather than in one sitting. So I think, you know, obviously, you know, there is a wealth of information available in written form. There is a lot of information that can be also given sort of in verbal form through sort of clinical appointments, through clinical nurse specialists, through myeloma info days, through helplines. So there's always a way in which to get that information which can be suited to whatever the patient needs are. And, you know, obviously having a good relationship between the patient, the nurse, the doctor, the team, is invaluable. You know, I'm very, very fond of many of my patients because I've known them for many, many years. And we've been on a journey together for many, many years. And, you know, that is because it is a partnership. We have to work together as a team.
That was really helpful, Fenella. Thanks for those hints and tips. I'm sure that patients will find those really valuable. We'd like to share a video with you now of a patient who shares his experience surrounded his diagnosis and the next steps that he took. So I'd just like you to introduce you to Douglas and hope you enjoy his video.
Good morning, it's early August 2020. I'm here in Cooper in Fife. My name is Douglas Abercrombie. I am a myeloma patient, diagnosed in July 2018. Luckily, there was an issue with that diagnosis insofar as my family doctor, my GP, had one patient who had experience of exactly the same condition and symptoms, and from that, luckily, he was able to send me for tests, but I'll come to that in a moment. Initially, the symptoms that I presented when I first thought there was something wrong was that I was losing my ability to concentrate. I was losing memory, just not functioning properly, and I didn't really know what was wrong. That probably started in the year 2015 into 2016, and I really didn't know what was wrong with me, but I knew there was something wrong, and I just wasn't right. I put it down to other stresses in family life and other issues. I didn't really think it was down to an illness at all. Then, around early 2017, maybe in the middle of 2017, I developed a very painful back, very sore back, certainly between shoulders. And I had been moving furniture, household material to some extent, and I put it down to a pulled muscle, torn muscle, or something of that nature that had hurt my back in some way. So I went to my GP. It turned out on that occasion that it wasn't my actual GP, it was another lady doctor who gave me a brief examination and said, well, I don't really know what it is, it's probably a torn muscle, but go away, and if it persists, if it doesn't disappear in the next few weeks, then come back and see a doctor. So I tried various pills, I tried various creams, ointments, and they certainly helped, but the pain did not go away. So a number of weeks later, I went back to the doctor, and it was my own GP this time, Dr. Gourling in Cooper, and he gave me a thorough examination, and he was obviously quite concerned about my situation. I explained all the various symptoms, and he was very interested, and he then said, well, I want you to go for x-rays and for an MRI scan. I thought at the time that was a bit much, that was over the top, but that's what he wanted, and as you do, you do what your doctor tells you. And obviously some 2 or 3 weeks later, the results came back to the GP, and he arranged an appointment for me to go and see him. I duly did, and he said, well, when I got into his surgery, his room, he said, you know, you better sit down, I've got some bad news for you. And I said, well, you know, what's the bad news? This was quite a shock, quite a surprise, and I wasn't expecting that at all. He said, well, I think you've got a condition called myeloma. Now, of course, I had never heard of myeloma at all. I wasn't familiar with the word or the condition or the disease, didn't know anything about it whatsoever. He said, well, myeloma is a form of blood cancer, he said, and it affects, amongst other things, it affects your bones and your immune system. The effect it has on your bones is it causes them to weaken and to crumble. And he said, that is what I think is wrong with you. And he says, the x-rays and the MRI scan have confirmed that 2 of your vertebrae and the top of your spine are badly affected, and 2 of your vertebrae at the bottom of your spine are badly affected. And he said that would account for the pain and the discomfort that you've been suffering. So he then said, well, he said, I cannot definitely diagnose myeloma. That needs to be done by the proper haematology team down in the Victoria Hospital, Kirkcaldy. So I'm going to make you an appointment with the consultant there, and they would get a blood test done, and they can then take it from there. So the blood test was done, sent away, and I duly went a few days later for the appointment at the Victoria Hospital, where I met with the consultant, Dr. Rogers, a very experienced consultant who'd been involved with haematology myeloma for a long number of years. He had received the results of the blood test, and he said, yeah, you've definitely got myeloma.
Special thank you to Douglas for sharing that part of his journey with us so far. We know that, you know, having a diagnosis of myeloma can be really overwhelming for some patients and families, especially to begin with. And here at Myeloma UK, as Dr. Fenella said, we've got lots of information and support that can be useful for you should you choose to access it. So including the myeloma info line, which myself, my colleagues Ellen and Sarah work on. You can call us anytime. We operate between the hours of 9 till 5, Monday to Friday, and we can provide you with support and information, and calls have no time limit. They're confidential and anonymous. We offer a listening ear, and we're there to support you as much as we can. So please don't ever hesitate to get in touch with us, because we really are here to support you as we can. We also have an email service if that's preferable for you. So you can either call or email us with your questions, worries, concerns, or just for a chat. That will be fine. We'd be happy to have a chat with you. We also provide patient information publications, as Dr. Fenella said, and that's a range of information from info packs to treatment guides to patient diaries, and you can access those on our website. Unfortunately, at the moment, we're not able to send out hard copies, but as soon as we're back in the office, we'll be able to post those out. But for now, you can access the information via the website. We also have myeloma support groups, and that's currently we've got about 95, I think, across the UK, and they're myeloma specific, the majority of them, but some of them are haematology based and accept myeloma patients and family members to those groups too. And it's an opportunity where people can share experiences and find information. They're very informal settings, and lots of patients get great benefit from attending those. Again, at the moment, due to COVID, they're not meeting face to face, but I know that some are meeting virtually. So if it was something that you're interested in, then, you know, give us a call or have a look on the website and we can give you more information about that. We also run patient and family events, our info days, and again, due to COVID, we're having to do those virtually, which has been a good experience for all of us, really. But again, patients and families can attend those and be part of gaining more information and support. We also have a range of videos on our website, and again, they range from patient stories. We also have videos on there that discuss treatments, that discuss what myeloma is. So again, you can have a look at the videos via our website. We also have an online discussion forum which patients can share experiences and ask questions. So if it's something that you have a question or a worry or a concern and you want to just have a chat, you can access the discussion forum there, and hopefully, you know, a patient will respond to share their experience of a similar situation.
So I think this is bringing it to an end, but thank you for all joining us today. I think there are 3 take-home messages, which is what we said right at the beginning, really. So the first is obviously myeloma is a cancer arising from abnormal plasma cells in the bone marrow, which we've obviously gone on to describe today. The causes of myeloma are not fully understood, and obviously that's an area which is of ongoing research. And that treatment aims to prolong life, prevent damage to the body, but also really important to achieve the best quality of life. So thank you very much for all coming today.
Yes, thanks for joining our webinar. It's been great to see you and talk to you, and a special thanks to Dr. Fenella, Willis and the team behind the scene for sharing their expertise. Please do keep an eye on our social media and website for announcements of further digital info sessions. Have a good evening, everyone, and thanks again for joining us. I hope you enjoyed it. Good night.
Good night.